Okay. We have one talk between you and the Worcester tea. So. No pressure whatsoever. So some of you, particularly people who grew up around Yale or at least grew up professionally here, know that in Virginia Henderson's definition of nursing, and in our mission statement for many years, we talked about that nurses not only nurse patients and families, but we nurse the system in ways to assure better outcomes for people. And so our last talk reflects that, and it'll be presented by Dr. Marge Funk, who's been a member of the YSN faculty since 1984. In case you're wondering why the lights are down, that was Marge is not trying to put you to sleep, but she worried that you wouldn't be able to see her slides. And for those of you who know Marge, you also note that Marge always color coordinates her outfits with her slides. So she has red and black. Marge received undergraduate degrees from Wheaton College and from Cornell University, the New York Hospital School of Nursing. Her master's degree is from YSN, and her PhD is in chronic disease epidemiology from the Yale School of Public Health. At YSN, she has taught statistics, research, and cardiac and critical care courses. And in her joint appointment at Yale New Haven Hospital, she helps nurses with research and serves on multidisciplinary committees to improve the management of clinical alarms. The focus of her research, her entire program of research, has been on the wise use of technology in the care of critically ill patients. The use of a particular type of technology, electrocardiographic monitoring, has been a thread throughout her research career. In 2008, Marge received a $3.9 million grant. I might add, parenthetically, it's the largest individual grant award that's ever been awarded to a Yale School of Nursing faculty member. From NHLBI at NIH for the implementation of practice standards for ECG monitoring known as the PULSE trial, and she'll be telling you about the PULSE trial this afternoon. Her honors include, last year, I believe, receiving the Catherine Lembright Award from the Council on Cardiovascular Nursing of the American Heart Association and the Distinguished Research Lecturer from the American Association of Critical Care Nurses. She is also a member of the American Academy of Nursing. Her research has provided an opportunity for her to mentor both students and practicing nurses at the bedside. She is co-chair of the Nursing Research Committee at Yale New Haven Hospital and helps the hospital nurses through all phases of the research process, including presenting and publishing, and has a clinical association with the cardiac ICU. The title of Marge's talk is A Multi-Site Randomized Clinical Trial on ECG Monitoring. Marge.
Turn it on, too.
Okay, you can hear me?
Yes.
Okay, I like podiums, okay? I'm just going to hold on here. So, thank you, Margaret. And as Margaret said, the name of our study is the PULSE trial, and PULSE stands for the practical use of the latest standards of electrocardiography. Clever?
Yes.
A little. So I'd like to acknowledge my the core PULSE team. So that's Chris Fenney, Janine May, Kim Stevens, and Barbara Drew. So although ECG monitoring is the cornerstone of care in hospital cardiac units, monitoring practices are inconsistent and often inadequate. So over 10 years ago, I was part of an interdisciplinary writing group that developed practice standards for ECG monitoring. Because the practice standards were based on expert opinion derived primarily from clinical experience and related research, they needed to be evaluated. So we designed the PULSE trial. We met with a group of interested nurses in Orlando in 2004. Who's that? It was a charming pink jumper back then. Kathy Knaffel had one just like it. So we obtained funding from the Beatrice Renfield YSN Clinical Initiative Fund to develop our online ECG monitoring educational program, and from the NHLBI to conduct the study. We assembled our core research team, as shown here, and established our research team colors of red and black. We created the official PULSE logo. We were ready to go. Our study took place in 65 cardiac units in 17 hospitals, 15 in the United States, 1 in Ottawa, Canada, and 1 in Hong Kong, as shown here, and I took a little geographic license with the placement of Hong Kong. We randomized hospitals to the experimental and control groups. The experimental group hospitals and the site investigators at each are shown here, and YSN alums are shown in red. We included both academic medical centers and community hospitals. The control group hospitals and site investigators are shown here. The site investigators are primarily advanced practice nurses, usually clinical nurse specialists, or hospital or university-based educators. So the PULSE trial is a 5-year, multi-site, randomized clinical trial to evaluate the effect of the implementation of those practice standards for ECG monitoring on nurses' knowledge, quality of care related to monitoring, and patient outcomes. The intervention consisted of an online ECG monitoring education program and strategies to implement and sustain change in practice, which was led by the champions on each unit. The PULSE trial is an example of translational research in which we tested the effectiveness of an intervention in real-world clinical practice. The online education was the first part of the intervention. It consists of 4 interactive modules: essentials of ECG monitoring, and arrhythmia, ischemia, and QT monitoring. This shows one of the screens from the online education where nurses practice placing electrodes. They use their mouse to drag and drop the electrodes onto the proper place on this image of the torso. They can then click Show Targets and to see if they put the electrodes in the right place. The second part of the intervention was strategies to implement and sustain change in practice. There were strategies that were required of everyone, as shown here, and then also hospital and unit-specific strategies that the site investigators and unit champions believed would facilitate improvement of practice at their sites. For example, at Yale New Haven Hospital, the site investigator and unit champions developed education on electrodes and alarms for the patient care associates. As I said, we're evaluating the effect of the intervention on 3 outcomes: nurses' knowledge, quality of care, and patient outcomes. This slide and the next one show the variables that we're measuring. So for nurses' knowledge, participants take a 20-item online test that covers essentials of ECG monitoring and arrhythmias, ischemia, and QT interval monitoring. For quality of care, PULSE research nurses evaluated a number of indicators, including the accuracy of electrode placement and rhythm interpretation, indications for monitoring, and a number of others as shown here. For patient outcomes, we used administrative data to determine the medical records that we needed to review. We evaluated mortality, acute MI after admission, and outcomes of cardiac arrest. These are outcomes that we thought could be improved with good ECG monitoring. This shows the design of the PULSE trial, a randomized clinical trial with crossover. A third time period allowed us to offer the education to control group hospitals and measure outcomes again. It also allowed us to assess the sustainability of any improvements in the experimental group hospitals. So why do you think we wanted to do that? I mean, why was it important to offer it to the control group hospitals? No. Because we were afraid that they wouldn't sign up for the study if we couldn't offer them something. Yeah. So for all outcomes, groups should be equal at time 1, or baseline. At time 2, the experimental group gets the intervention, and they should be better than the control group at time 2. So time 2 here, experimental group is better than the control group, and also better than it was at time 1. At time 3, the control group gets the intervention, and the experimental group and control group should be equal. The control group should be better than at times 1 and 2, and the experimental group should sustain their higher level and be the same as they were at time 2. So the study was funded through March of 2013. We obtained a no-cost extension for a 6th year through March 31st of 2014, primarily because I had to put the study on hold for IRB issues during the summer of 2012. We finally completed all data collection in October of 2013, and data analysis is in progress. That's co-investigator, pulse statistician Chris Fenney, and his able assistant Arthur Funk. So today I'll report the preliminary findings, because Chris just left last night, so I was working on stuff until midnight, so preliminary. So for the 3 outcomes of nurses' knowledge, quality of care, and patient outcomes. So for the nurses' knowledge aim, our sample contained 3,013 unique nurses working on cardiac units in 17 hospitals. So for the purpose of this presentation, I'm including monitor techs who entered the study at times 2 and 3 when I refer to nurses. Only 5% of the sample were monitor techs. At time 1, all nurses completed the online ECG monitoring knowledge test. Hospitals were then randomized into experimental or the control group. The experimental group nurses received the online education at time 2, and the control group nurses received it at time 3. So as I said, there were 3,013 unique nurses, 686 of whom participated in all 3 phases of the study. The mean age of the nurse sample was 35 and a half, and ages ranged from 19, I'm not sure why 19, but, and up to 71. The sample was 89% female, about what we expected, and 76% white. 73% had a bachelor's degree or higher, and almost half perceived their expertise related to ECG monitoring to be about average. So this shows the knowledge test scores over the course of the study, with the experimental group in blue and the control group in red. So as predicted, the mean test scores improved significantly to 70.2 and 71 in the control group. So 70.2 in the experimental group and 71 in the control group immediately after they each had their intervention. However, in the experimental group, 12 to 18 months later, after the intervention, the mean test scores declined to 59.4. So while 59.4 is significantly lower than the immediately post-intervention, it's significantly higher than the pre-intervention scores. The group by time interaction is significant, meaning that the change over time in the control group is significantly different than the change over time in the experimental group. In other words, the lines are not parallel. Of the 4 subsections of the test, Essentials of ECG Monitoring had the highest mean post-test scores, and ST segment ischemia monitoring had the lowest. As expected, the post-test scores for the control and experimental groups were very similar, and the pattern of change for all subsections was similar to that on the entire test, as you saw on the last slide. So we concluded that although test scores improved after the education, gains diminished over time, but were still better than at baseline. So whether the improved knowledge translates to better quality of care and patient outcomes will be determined. Additional analyses that we've planned include evaluating the influence of demographic characteristics of nurses, as well as hospital and unit characteristics. So, will those variables have any influence on the test scores or the improvement of scores? And we also plan to do a number of subgroup analyses. Our second aim was to see if our intervention had an impact on quality of care related to ECG monitoring. So our sample included observations on 4,587 patients on the 65 units in the 17 hospitals. Over 5 days at each time point, Pulse research nurses observed care on the participating units. So that was Janine May and Kim Stevens, as I showed you on the first slide. They observed monitors and electrode placement, reviewed the current medical records. They compared arrhythmias stored on the monitor with documentation by unit nurses. The mean age of this sample was 65 and a half, again, about what I would have expected. The sample was 83% white and 57% male. 1/3 of the sample had a non-cardiac diagnosis. Remember, this was all cardiac units. The most common cardiac diagnosis was acute MI or rule-out MI. So there were significant differences between the control and experimental groups for race and for primary diagnosis. So we needed to control for those variables in subsequent analyses. So we evaluated electrode placement, proper placement of monitoring electrodes on the torso, as seen here, is essential. Misplacement off the designated site can alter waveform morphology and lead to misdiagnosis of arrhythmias and ischemia. I'm so glad I have notes. I'll have a drink. Okay, so the majority of patients, please hold. So the majority of patients had the standard 5-electrode configuration as seen on the previous slide. So this shows the percent with accurate electrode placement for 4 electrodes at the 3 time periods in both groups. I didn't include the right leg electrode. Why? It could be anywhere. It can be placed anywhere on the body. So placement was consistently almost perfect. But we still found it to be incorrectly placed on occasion. Where was it? In the bed rail, patient's gown, different places. It just didn't work as well. So look at time 2 in the experimental group. So for each of these electrodes, at time 2, what was that? So after the intervention in the experimental group, the percent of the accurate electrode placement is better than, was it something I said? So it was better than it was in the control group, right? Across on all of those. And also, it was better than it was in the experimental group at baseline. at time 3, what was I going to talk about time 3? When the control group received the intervention, it improved from the control group accuracy at times 1 and 2. And you could see that the experimental group was actually also improved from what they were. So they not only sustained, but they still got a little bit better. So we use generalized linear mixed modeling. So it is when I speak, it happens.
Not sure what it is, but.
Oh, good. I didn't say anything that time.
I think so.
Reject.
Or uncertainty.
That's a website. That's not a phone number.
Yeah.
That's a web address.
Yeah,
Well, tell them they're rude. We're in the
I know, right? Okay, then.
running out of time. You won't see my best slides in the end.
This one has. Yeah, I like that. I like that object. Is this a test?
I know, right?
Can you say the last one?
Can you accept and tell them that we don't want to talk about it?
Yeah, just mute the, yeah, just mute it. No, it's three, we're still online. Then it might be.
Talk amongst yourselves.
Okay. Great. Okay.
Well, I can tell you a little bit if you want.
There you go.
Oh, shoot. Thank you, Neil. Okay, so I was saying that we used generalized linear mixed modeling, which we took into account hospital and unit variation as a random intercept. And we also adjusted for race and primary diagnosis because they were different across the two groups. The p-values in the last column represent first group differences. The second p-value represents time differences, and then the group by time interaction. So of particular interest is the results for the B lead. So at baseline, the percent with the correct placement, which we defined as any of the 6 B lead placements, was pretty low, especially in the experimental group. So like not even 20% got it right. But both groups showed significant improvement after the intervention. So the experimental group went up to 59.3% and then up to 65%, and the control group went up to 62% after the intervention. But the p-value here of less than 0.0001 for the interaction indicates that the change in the experimental group is significantly different than the change in the control group. So this graph shows the accuracy of documented rhythm interpretation. The rhythms that we evaluated here are the non-life-threatening arrhythmias. We hope that they'll always interpret the life-threatening arrhythmias correctly. So we included here things like atrial fibrillation, non-sustained VTAC, supraventricular tachycardia, short pauses. So after the intervention in the experimental group at time 2, the accuracy of documented rhythm interpretation was significantly better than, here we go. So that's significantly better than in the control group, and also significantly better than it was at time 1. At time 3, the control group came up after they received the intervention, and it was similar to the experimental group, which was sustained. And this was 12 to 18 months after the intervention. And here the group by time interaction is 0.0026. So with the increasing concern about alarm safety and sentinel events related to alarm fatigue, we evaluated the appropriateness of monitoring in non-ICU settings. I mean, everybody in an ICU needs a monitor, but it's not clear that everybody who gets a monitor outside of an ICU really needs it. So we looked at the percent of patients on a telemetry monitor who had no indication to be monitored according to the American Heart Association practice standards for ECG monitoring. So we found that the percent of those on a monitor with no indication declined significantly at time 2 after the intervention in the experimental group from the 34 at baseline to the 30.4% at time 2. And also after the intervention at time 3, in the control group it went from 40.6 and improved to 28%. And this improvement was maintained at time 3 for the experimental group. So at time 2, you can see that after the intervention in the experimental group, that the difference between the groups was significant at p of 0.0004. And again, the group by time interaction was significant. So we concluded that education and strategies to improve practice can result in enhanced quality of care related to ECG monitoring. So whether the observed changes will result in improvements in patient outcomes will be determined. We have many additional analyses to do. There are many other markers of quality of care that I've not reported on today. We plan to look at the association of quality of care with nurses' knowledge and hospital and unit characteristics, and we'll also do a number of subgroup analyses. So for patient outcomes, our last aim, our sample was all 95,884 admissions to a participating unit, now in 13 hospitals, not 17, over 6 months. We used administrative data and lab data to identify a subset of medical records to be reviewed to determine mortality, MI after admission, and outcomes of cardiac arrest or CPR, including whether the patient survived the event, survived a hospital discharge, and was discharged home. Finally, we analyzed whether our intervention was associated with a variable that we created that was a composite of these three. So a composite of mortality, MI after admission, and not surviving a cardiac arrest. So this shows the characteristics of our patient outcome sample. Of note is that over half had a primary, now we're talking about a discharge diagnosis, that was not cardiac. Also, the outcomes that met our criteria occurred pretty infrequently, which is what we expected and why we needed such a large sample size. So mortality was a little over 3%, MI after admission 2.3%, and an arrhythmia arrest that met our criteria occurred at only 0.2%. So results of the analysis of the composite variable of mortality, MI after admission, and not surviving a cardiac arrest event are shown here. So at each time point, including, unfortunately, a baseline, the rate of these adverse events is significantly lower in the experimental group. Generalized estimating equations analysis shows that the rate in the experimental group is significantly lower than in the control group. Okay, so that's the group comparison. It also shows that the rate of these adverse events is significantly lower at time 3 compared with time 1. But the interaction is not significant, shown at the bottom there, meaning that the rate of decrease in the experimental group is not different than the rate of decrease in these adverse events in the control group. So there's evidence that our intervention had an effect on nurses' knowledge, quality of care, maybe even on patient outcomes. It appears that the randomization, however, may not have been completely effective, perhaps because we only had 17 hospitals, and these hospitals had a lot of variability. So we still have much to do and hope to be able to complete our analyses this summer and present and publish our results. So the PULSE team will continue our work. This is our annual site investigator meeting that we have at the critical care nurses meeting every year. So as you can see here, we try to wear our official PULSE sweaters at all official PULSE events, such as our annual meetings. Now these PULSE sweaters, I thought about wearing it today because it really is very attractive. It's a black sweater adorned with the white hearts and 2 randomly placed red hearts. So it really was kind of perfect for our study. And we just feel it's important to wear, you know, the research team colors at all these events. Don't you think? Yes. That hadn't been discussed earlier. You don't do that, Ada Sue? So here we're holding the official PULSE banner and wearing our PULSE jackets now. They have the PULSE logo on the front and a rhythm strip of normal sinus rhythm on the back. Who's that in the front there?
That would be on.
That's Annie.
We won.
So there are official uniforms when we compete in the U.S. National Toboggan Championships. In our first year competing, the PULSE trial had 2 teams. I was on the PULSE team, on the left there, and we didn't do very well. But Team Pulseless made the finals and had the second fastest time of the all-female teams. There's over 400 teams in this. This is national. Who are these people? Annie's in the front. Moira O'Neill, an alum of both our master's and our PhD program. And Fran Hackerman, who's the administrative assistant for the PULSE trial. Those were the members of that legendary team. And this past February, we now had 5 teams from the PULSE trial and from YSN. So we had PULSE, Pulseless, VTAC, Fast and Deadly, the AFib All-Stars. Pat Jackson-Allen was on that. And the Red Star Alarms. So back to the statistics. As shown here, our times were respectable, although none of our teams made the finals. For the 3-person division, on the left, of the 100 teams, VTAC Fast and Deadly was 52nd, and Red Star Alarms was 56. Well, Laura, what were you on?
Pulseless.
You were Pulseless, okay. So here we are on the right now for the 4-person team division. So there were 200 teams in that division. Pulse was 77th, and we missed being in the finals by only 1/10 of a second. Heartbreaking. Sorry.
You still get choked up.
I do get choked up. Pulseless was 84th, so that was Laura and Annie and Gwen and Moira, right? Yeah. And the AFib All-Stars came in exactly halfway at 100th. So that's Pat Jackson-Allen, Pat Ryan Krause, and their respective husbands. So my point in showing this is that on the graph on the right, I indicated that the worst time was 11.87 seconds. But that's not actually true. One team hit the side of the chute and fell out. They got back on their board and finished in 49.46 seconds. Including this outlier would have increased the mean time by a lot and really messed up the aesthetics of a graph. So, you have to consider these things when you present research. So the Pulse trial afforded us an opportunity to participate in the U.S. National Toboggan Championships, but it was more than that. We hope that the results will lead to better practice related to ECG monitoring and improve patient outcomes. It's very clear to me that for a large, complex, multi-site study to be successful, you really need an outstanding research team. And I was fortunate to have the very best team, no offense to the rest of you, including the core Pulse team, the site investigators, and the unit champions. So we really do bring our banner wherever we go. That's at the Yale hockey rink there on the left. So over the years, the Pulse research team has also included numerous YSN students and staff whose names are shown here. So I'm grateful to them for their unique and very important contributions to this research. That's it.
Want to take a question or two?
Yes.
I was curious about when you presented about the AIM-1 statistics with the follow-up on the nurses 18 months after their training. Were they still on the floor that they had started on? They hadn't moved to the floor?
A few did. That will happen. But, we decided that we would include everybody, thinking that, all right, maybe you didn't have baseline, but we were hoping to improve the culture on the unit. So even if you didn't participate at baseline, you are now working in a culture where the expectation of improved ECG monitoring was there. Lois?
So to that point about culture, so your champions were the ones who did what?
So there were site investigators at each hospital, and then they appointed champions in the unit. So those were the people who encouraged the staff to take the test, to do the education, to participate. We had two hospitals at the last part who achieved 100% participation, one being Yale New Haven. Paula, were you working on 5.2 then?
No.
No, we started after.
When you started?
2008.
Oh, I was there.
Well, you would have remembered it was a lot of fun to participate in this. Yeah. So, and then they thought about, okay, they did we had a class about implementing and sustaining change in practice, which they went to. We talked about how to, what are the unique issues in your unit that might prevent optimal ECG monitoring. So they thought about things that were particular problems in their unit. And also we had posters that they hung up, and we had case study, follow-up stuff. So those were kind of like the people who, in all the units now, you've got people who are the fall champions and the pressure ulcer champions. So these were the most champions.
Was there any relationship between the tobogganing and main and dropout of the main site?
No, you did notice that the Bangor site dropped out, and that
It dropped out
was,
of my city too, that's why I was interested.
yeah.
Mm-hmm.
So the moral of the story is don't
Don't
sign
go
them up. But they, the reason we had a problem, the site investigator there was Rebecca Henry, who's a YSN graduate a while back, and she lost her job. And she was the only one, she was the main person there, and we talked about, well, should we find somebody else? And there really wasn't anybody else, so we had to they
Yeah.
dropped out.
So you had a dropout in each of you had dropout in control and a dropout.
Yeah, they were in the experimental. We had one hospital drop out in the control group. And they were by far our worst performing hospital. They just didn't care. We had some really, really good hospitals who participated in everything. So that's one of the things we're going to look at. We've collected data on how exactly did you implement the intervention and how many, what percent of the nurses participated in the education and all of that.
So I'm going to ask you facetiously, I was wondering when in the trial they dropped out and if you have data.
No, it was before the Toboggan Championship. So there,
No, I meant in relation to when they should have started.
Huh?
So I assume you started the intervention, or you start, time zero was the same for all
Yeah, so they,
hospitals. And so when did the dropouts drop out? And did you have any
the
data?
Eastern Maine Medical dropped out right when they were starting the intervention, so only a couple of nurses had done it. The other hospital was in the control group, so they were to have the intervention at time 3, and that's when they dropped out. So we use some of their data, we use what we had.
Yeah.
And we struggled with whether, to drop those 2 hospitals from the whole thing and decided not to. And then for patient outcomes, we had 2 hospitals that were not willing to give us patient outcomes data. So we had 13 instead of 17, Pat.
So what do you, this 50% who didn't have cardiac diagnosis, did that affect your outcomes? The
That's
nurses?
what we're looking at. So we have to control for that and the quality of care. What we're struggling with is we did the patient outcomes analysis yesterday afternoon and trying to figure out really how to model that, because with almost 96,000 patients, you're going to have differences between the groups, and you control for all of those things. And, I looked at the differences, and, they're clinically unimportant. So I'm not sure, but the one thing we did learn, because we're revising the practice standards now, is that we've got to go way beyond cardiac patients here. And we didn't do a good enough job, I think, initially with that. Okay, then.
Thank you.